All right, let's start. Good morning, good afternoon, and good evening to everyone who joined this meeting from different countries and time zones. Hopefully, everyone is doing well. My name is Yulin Ji, Professor of Radiology at New York University and the President of International Society for Neurovascular Disease, or ISNVD. It is my great pleasure to welcome all of you to this webinar organized by ISNVD. ISNVD is an international society focusing on neurovascular-related disease. Our mission is to provide excellent research and education, in particular to disseminate and review the new concepts of disease mechanism, as well as the novel diagnosis and therapeutic strategies in various neurovascular and neurodegenerative disease. We hold seminars and workshops regularly, and you're welcome to become a member of our society and collaborate with our members on many research topics. Before this meeting begins, I would like to thank Dr. Editorial Toro, who organized today's webinar. Dr. Toro is a professor of applied mathematics laboratory at the University of Trento in Italy. He is also an EC member of ISNVD. One of his research interests is to develop the mathematical modeling to study the body fluid dynamics, including the blood flow and the CSF. And you will hear from his lecture later. Dr. Toro will first give a brief introduction of today's webinar. So, Dr. Toro, it's all yours.
Okay, thank you very much for that introduction. Welcome to this workshop. It is a meeting about neurofluids, about physiology, methodologies, and obviously neurological diseases. The focus behind, or rather the background to this workshop are obviously neurological diseases, but the focus of this particular meeting is on the basic science behind the physiology, methodologies, methods of study, a highly interdisciplinary task really to face these very challenging problems. And we have participation of medical doctors, physiologists, physicists, engineers, mathematicians even. So I thank the participants and contributors to this exciting workshop. And I think it's going to be a very interesting event, presentations and the following discussions on this topic. Welcome to the meeting. And now I will present you the chairman of the chairperson of the first session of the meeting, Dr. Mei-Yung Wang. Please.
Thank you very much, Dr. Toro. Hello, everyone. It's my great honor to chair the first session of this webinar meeting. I think we all look forward to the great lectures. The first speaker is Professor Helena Ben-Vanist. She's a professor of anesthesiology of Yale Medical School of USA. And she's very famous in lymphatic pathway study. And her topic is MR method to start lymphatic fluid flow dynamics. Welcome, Professor Ben-Vanist.
Thank you very much. And I want to really thank Dr. Toro and Dr. G for offering me this opportunity to talk today. We have a lot to cover, so I'm going to dive directly into it. And can you see my screen? Everything is okay, I hope, right? So what I'm going to talk about today is more about the methods and focusing on lymphatic and lymphatic fluid flow dynamics. And before I start, we always end with thanking our collaborators. I really want to do this up front. Dr. Hedok Lee, Dr. Kundel, Brittany Monti and Mason Pedram from the lab especially has been participating in this data that I'm showing today. And we couldn't do this without Dr. Alan Tannenbaum's team, who's also going to be here for the discussion and save me when we get to the mathematics. But with this, these are my disclosures, and let's just overview what, this is just what I want to talk about, the concepts of lymphatics, and everything I'm showing you is based on dynamic contrast enhanced MR. And we are doing some new things, not only in whole brain, but we're also looking at the lymphatic part of the system, which I think is really important to focus on. So as you all know, the lymphatic system has been introduced in 2012 by Dr. Nedergaard's team, and is a focus of an increasing number of studies. And there's a lot of debate and controversy and discussion about this system. But what I want to highlight here is that this is what we sort of are schematically thinking of the system. So we have a perivascular network of channels wherein cerebrospinal fluid flow can actually enter into the brain parenchyma and exchange with interstitial fluid. And doing that, there's a drive and a mix that actually can remove extracellular waste solutes out of the brain. And most studies are showing that there's a perivenous outflow, and then there's a connection to the meningeal lymphatics, and then to the cervical lymph nodes, and to the systemic circulation. So what I'm trying to do here is just not focusing only on the lymphatic system itself, because obviously it's not a system that stands alone without cerebrospinal fluid influx and without a connection to the drainage pathway. This system is really non-functioning. So this brings me to this concept that we are starting to develop, and that is more talking about coupling versus decoupling and developing methods that will allow us to study these processes. So the synchronous coupling between cerebrospinal fluid inflow into the lymphatic system and drainage would go on as I have depicted here. We have maybe advective CSF inflow, we have some lymphatic transport and exchange, and then we have an outflow that involves meningeal lymphatics that drains to especially the deep cervical lymph nodes. In the sense of when we get to disease states, obviously there's going to be some form of decoupling of these processes, because the lymphatic system as we know it may not actually be accessible because of amyloid deposition and other waste proteins that are accumulating in the interstitial space. And we really do not know much about what happens in these circumstances. Does cerebrospinal fluid bypass directly to the meningeal? And what is the consequences, let's say, of this type of decoupling? The methods that we have been working with, I think since 2012, we developed this in collaboration with Dr. Nedergaard's team. And it's a very simple method. We inject a small molecular weight gadolinium-based contrast agent into the cisterna magna, into the CSF, and we use the rat. Mostly because it's bigger, we have more spatial resolution for our data, and it's a bigger animal compared to the mouse, obviously. And normally we have the rat in a supine position, spontaneously breathing, and anesthetized, usually with dexmedetomidine and a low-dose isoflurane. And I'm only mentioning this so that you know what kind of data I'm showing you, because of course anesthetics matter in terms of the efficiency of lymphatic transport. And these are some very early data. Here we used a low molecular weight gadolinium-based contrast agent that actually over a 2-3 hour period, you can see it penetrates into the brain parenchyma. These were studies that I developed early on with Dr. Hedok Lee. And we also used a large molecular weight contrast agent, gadospin, P, which is bigger and really takes much longer to pass across the perivascular boundaries, the end feed gap between the glial cells and into the parenchyma. However, if you wait long enough, there will actually be some passage even of this large molecular weight contrast agent, but it takes time. And we have been working on this in different situations. We usually use a very diluted concentration of gadolinium in the rat to not infer too much osmotic pressure from the contrast agent itself. However, that has a, it's a trade-off. You don't get a lot of signal to noise when you do that. And in some instances, you really need higher concentration of the gadolinium-based contrast agent. And here you can see this is parametric images, percent signal from baseline, and you can see how it goes in and it exchanges, and over time it goes out. We have also developed a higher spatial resolution platform along, this is work by Dr. Kundal in the lab, who developed this so that we can actually look better at the perivascular space along the PL artery. The perivascular space are much larger here, and we can look at fluid flow dynamics better because we simply have more signal to noise and more spatial resolution. Let me go to the next one. So this is some totally new data that I'm showing here today, fresh off the magnet, so to speak. And here we are looking at a new method based on same technique of contrast enhanced MR, but we are putting the coil here over the neck so that we get a slab of tissue that allow us to look at the little bit of the brain spine. We can see the cervical lymph nodes. Here you can see the deep cervical lymph nodes are receiving contrast. And again, we are using GATOspin for many reasons that I can explain to you later. And I just want to mention that, this is noisy data because we are close to the carotid arteries. If you use flow compensated sequences, you lose signal to noise. So there's a lot of trade-off here, and I will try to mention that. But the most important part, I think, is that we can start to look at the individual lymph nodes. This is again the rat. We have the submandibular lymph nodes here in the midline. We have some parotid lymph nodes more laterally, and then we have the deep cervical lymph nodes lying here in very close to the carotid. And here is just reminding you how a lymph node look like. I'm a neurobiologist, and this has been new data for me, and it's really intriguing. I just want to really emphasize that the anatomy is complex and very variable. Also, if you have genetically identical mice and rats, the lymph nodes, they vary in size. Sometimes there's one, sometimes there's two, for example, on one side of the deep cervical. And it's not like a noise-free system, I would say. And I've highlighted all the arteries here on the neck, the internal carotids, external common carotid, and you can see that the deep cervicals are lying here hidden, I would say, mostly at the level of the carotid bifurcation laterally. And if we start looking at contrast moving into the node, it's, as I said, noisy, but we can capture it. Here's a movie showing GATOspin moving into the node. This is a spatial resolution of about 200 micron in vivo, and you can see the capsule here. You can see some subsections of the node, and you can see an afferent. You can't see the afferent, but you can see the efferent. And when you look at the nodes from right to left, the drainage capacity, if you believe that this is drainage, this is a signal coming from the GATOspin reaching the node, you can see it's pretty symmetrical. And if you sum the data, over 2.5 hours, you can get nice images. And here what I've done is we have segmented all the signal that is attached to the deep cervical lymph node here on the right side. And the streams that we see that are the major streams are not along the veins. They actually look as if they are along the arteries. And this is not something new. I think other people have been reported that in the past. We certainly have, but we are starting to study this more closely. And back to how we quantify. We have done a lot of different quantification. Mostly it's been based on time signal curves from the signal, signal from baseline. You can convert this into mass, like the gadolinium molecule mass. But normally we do percent signal from baseline. You can do kinetic modeling, but mostly what I will talk about today is the computational fluid dynamics that we are doing in collaboration with Dr. Tannenbaum team. Just briefly on the kinetic modeling, you can do this simply by doing brain morphometry, so you can segment out all the cerebrospinal fluid, you have brain parenchyma, and then you get these signal curves, let's say, only from the CSF and only from the brain parenchyma. And you feed that into a 1 or 2 compartment model, and this is whole brain data. And you can get an influx rate, you can get maybe a rate constant that represents an efflux, and you can get total input. This is work by Dr. Mortensen, Nygaard Mortensen in Copenhagen, in collaboration with Dr. Nedergaard. And we have developed this, we started using this, but it has limitations. It doesn't give us voxel-wise information, and it has a lot of assumption like instant mixing, which does really not hold true for this system. And this is why we started working with Dr. Tannenbaum's team actually in 2014. And everything that I'm showing you now is based on this new algorithm that we have developed and refined. Dr. Tannenbaum is famous for the optimal mass transport theory. And I worked with Dr. Rina Elkin. She was a graduate student. She is now a physician scientist in the medical physics department, and working now with Xinan Chen, who's a grad student, also working with Dr. Tannenbaum. And what we are doing is regularized optimal mass transport for analyzing the lymphatic system. And I'm not going into the mathematics, but it's based on Monge and Kantarov's transportation problem, which is considering the engineer's problem of transporting a pile of soil into an excavation here with the least amount of work. And there's a ton of mathematics in this, but briefly what I want to mention is that it actually includes 2 key transport processes, advection and diffusion, into the model, while also adding the natural physical property of energy minimization into the model. So really these are the only assumptions that we have. So the image intensity we are using the image intensity from our images to get information about the movement of the solute. And just a little more information here that just highlights again that we are implementing both advection and diffusion. And again, that it does not require a priori specification of the system configuration or material properties. So we don't need to actually put in local pressure gradients and sizes of the vessels. We may have to do that lately, but we are not doing it at this point. And it's been used in numerous applications. Weather systems, I'm showing you here, these are data from Dr. Tannenbaum. And he always reminds me that really we are looking at the data. It's a data that defines what the algorithm actually, spits out. Here you have a beating heart from MR data, but it's not a real live heart. It's a beating heart derived from the algorithm. We have to keep that in mind. But this is a pipeline that we get. So we have the contrast enhanced images. We put it into the model. The model is actually spitting out a lot of different metrics. So we get path lines over 2 hours. It's a Lagrangian formulation of fluid flow. So we get a 2-hour kind of view of the flux. It's a volume metrics of the lymphatic movement. And we also from these path lines can get the mean relative speed, and we can get velocity flux vectors. And using a segmentation, we can look at solute speed in different compartments. So we can look at CSF and tissue separately. And here's some examples. I just want to give you examples of this. metric of, let's say, lymphatic flux. So here it's the brain parenchyma. Now the brain parenchyma also contains a little bit of perivascular spaces. It's not only a neuropil, it's not only tissue, but it's the brain parenchyma. And here you can see we have taken a lot of different rats at 3 months, 6 months, and 12 months. And you can see that the CSF flux seems to be constant over time, at least from 3 to 12 months in these normal Sprague-Dawley rats. When you look at lymphatic flux, how much of moving solutes actually moves into the parenchyma, you can see that there's an increase from 3 to 12 months of about 20%. So it looks like as the rat brain matures, it gets a little better in terms of lymphatic flux efficiency. And this has nothing to do with the brain growing, because the brain grows only about 4% during the same time interval. If we look at speed, it's very interesting. Obviously, speed in this pure fluid is very fast. And when it hits the brain parenchyma, it slows down. Here's the CSF speed, arbitrary units, mean relative speed of the compartment in 3, 6, and 12 months rats. And you can see it's pretty constant. Same thing with the tissue speed. It's sort of much lower than the CSF speed. It shouldn't surprise us. It's an extracellular molecule that we are looking at. And you can see it's also steady over time from 3 to 12 months. This is a velocity flux vector analysis, which I find most intriguing. The magnitude or the length of these vectors are indicating the distance of how far a solute was moving over the 2-hour period. So it's kind of a reflection of the speed. And the velocity phase indicates the direction. And if we start looking at this in more detail, this is on the ventral surface of the rat, you can see that the flux vectors are very symmetrical around about the midline, and they're very strong close to the circle of Willis, near the large perivascular spaces. And once they enter into the tissue bed, they seem to slow down. If we turn the rat upside down and look at the top, you can see here's a pineal CSF reservoir. There's also a lot of activity going on here in terms of cerebral spinal fluid flux, very strong velocity flux vectors moving out. And we find this intriguing because this area is right about the dura. And we all know from Dr. Alitalo and Dr. Kidney's lab that there's a lot of lymphatic vessels sitting here on top. So it looks like we have a lot of dynamic cerebrospinal fluid flow in this area. And these are the things that we can start to study. We have also been interested in knowing what is advective and diffusive here from these vectors. And Dr. Chen, in collaboration with Dr. Tannenbaum, had developed an algorithm based on the directional pattern of the velocity flux vectors to come up with a way to separate advective from diffusive vectors. It's not perfect, but it's close. And what you can see here is that we have advective, these are the red arrows, lots of advective arrows pointing from the CSF. The black mask that you see here in the background is the CSF compartment, and you can see these advective arrows is originating from the CS and pointing into the tissue bed. And you can say that advective flow is a driving force of this system, but that diffusion takes over. And as Alan always tells me, diffusion always wins. So it slows down. So you have this advective stream, and then it becomes diffusive. And I find this very intriguing, and you will see how, in the future, it's really different in disease states. Lastly, I want to just show you some new data from this other system that we are looking at, because we need that other part of the system to be able to talk about coupling between CSF flow dynamics, lymphatics, and efflux. And this, as I said, is kind of a new platform for us. These are lymphograms, lymphoclams. I call them over 2.5 hours. Summed, it's normalized to the cerebrospinal fluid flow. You can see the spine is here, and this is the rest of the brain, and you see the arteries. And here on each side, you can faintly distinguish the deep cervical lymph nodes. And as I said, it's a messy region, but you can see the deep cervical lymph node here. And when you sum and start segmenting streams that are tied or connected to the lymph node, you can start to see these streams along the internal carotid and the external, and also in the bifurcation. It's much more difficult to look at the afferent lymphatics going into the node than it is to look at the efferent. We don't really have good enough spatial resolution yet. These are, again, highlighting the time signal curves from 10 different nodes from normal female straight dolly rats that are 3 months old. And you can see it's a very noisy. It's not totally noisy. There's symmetry from left to right, but they, they don't drain to the same amount. The magnitude is a little different. However, the temporal profile seems to be pretty solid. So it looks like it's peaking about, 70 to 90 minutes after we inject the contrast tracer into the CSF. So it takes some time for the solutes to actually reach the node, which have been demonstrated by other investigators. So this is corroborating these data. And again, this is rat data. So this is a deep cervical. You can see we get quite a bit of drainage here. In the parotid lymph nodes that are more lateral, we see much less. And it's kind of the same temporal profile, but most of the rats actually don't get much into the parotid. And I find this intriguing for many reasons, because these nodes here that are very close also don't receive any contrast at all. So this is a deep cervical and parotid. These are the only active nodes, at least in our system. And finally, what I want to show you is the attempt to do optimal mass transport on this data. We are masking out these streams. And I find it intriguing that in most of the rats, we kind of see very strong stream along the external carotid arteries, much less so from the internal. And they're pointing towards the lymph node here, very high magnitude flows. Now, this doesn't mean that it's, it's in the perivascular space or in the sheath itself. The streams are distinct along the arteries. They are in specific conduits, and we believe that they are actually authentic lymph vessels, which is a little bit of a different perception of this whole system, because obviously I was imagining that it would be perivenous drainage. The internal jugular vein is very small in the rat, so this may be very well different in humans. But in the rat, it looks like we see this pattern in most of the rats that we are studying. The signal streams here along the efferent and afferent vessels are very weak. So we need to do better in terms of signal to noise and resolving these flow streams in order to get better information. So in conclusions, I think we need to get our techniques to focus on the crosstalk between CSF compartments, cerebrospinal fluid flow, lymphatics, and drainage. This is really important. And we can do that by combining MR with contrast-enhanced MR with optimal mass transport algorithm, because we get a lot of different metrics that can inform us about the crosstalk. And we have now also shown that we can start looking at the other side of this system and start looking at the draining cervical lymphatic nodes. And I'm very excited about this. Unfortunately, this is all because I don't have more time, and I want to thank you all for your attention.
Thank you very much, Professor Ben Van Nist. It's a great lecture, very amazing. So I think there may be some questions from the audience, and I have seen some, but please post your questions in the Q&A box, and we will address during the discussion time at the end of the first session after 3 lectures. So now let's move to the second lecture. The second speaker is Professor Shinjin Naganawa from Japan. He's a professor and chair of Department of Radiology in Nagoya University Graduate School of Medicine. He has recorded a video for the lecture, and his topic is towards the visualization of NEUROFLUIDS dynamics by MR using IV-GBC, please.
Hi, I am Shinji Naganawa from Nagoya University, Japan. Thank you for having me here today. This is my disclosures. Today, I'd like to briefly talk about the lymphatic system hypothesis and IPAT hypothesis. And I will briefly cover imaging methods, and I will mainly talk about the parasagittal dura and related structures, which is a unit in the downstream part of lymphatic system. This is a comprehensive schematic diagram of perivascular drainage pathway or IPAT pathway and lymphatic pathway. IPAT, intramural periarterial drainage pathway. In this system, interstitial fluid drains through the arterial wall itself in the direction opposite to the arterial blood flow and finally goes to cervical lymph node. In the lymphatic pathway or paravascular pathway, CSF enter through a aquaporin 4 channel in the end feet of astrocyte to the brain parenchyma and exit through a paravascular space, paravenous space, washing out the waste from the brain. The CSF in subarachnoid space is drained from arachnoid villi when the intracranial pressure is high, and also through a olfactory nerve area, but mainly through a meningeal lymphatic vessel, and finally goes to cervical lymph node. We still don't know the ratio between the two. As you know, lymphatic system function is active during sleep, and function decreases by traumatic brain damage, subarachnoid hemorrhage, and infarction. And function is closely related to Alzheimer's disease, glaucoma, normal pressure hydrocephalus, and Meniere's disease. For MR visualization of lymphatic function, gadolinium-based contrast agent GBCA injection into CSF space is usually utilized both in animal and in human. Of course, intrathecal injection of GBCA is contraindicated for clinical use. There are many methods for the lymphatic MR, but today I will mainly focus to IV GBCA. But this is a paper from Norway which utilized intrathecal GBCA. The GBCA injected into CSF space is absorbed in the parasagittal dura, the yellow part, like this. They measure the signal of this PSD, parasagittal dura, serially after intrathecal injection and draw a time intensity curve. And this is a curve for parasagittal dura and CSF. These seems to be parallel. And this is schematic diagram. Yellow part is parasagittal dura. This is coronal view, and this is superior sagittal sinus. And this L is meningeal lymphatics. And in the parasagittal dura, there are small arachnoid granulations, and C is a channel, a water pool in this PSD. And the cortical vein penetrate this parasagittal dura. So this structure seems to be quite complicated and seems to have some functions like a filter or like a lymphatic tissue. So let's talk about the IV-GBCA. For the visualization of endolymphatic eye drop of inner ear, we usually obtain these kind of pictures after IV-GBCA. This is pre-contrast, heavily T2 weighted 3D flare. This is 5 minutes and 4 hours. After 4 hours of IV-GBCA, CSF is enhanced as well as the perivascular space in basal ganglia is enhanced, even in the subject without a significant blood-brain barrier BBB disruption. This is heavily T2 weighted 3D real invasion recovery image obtained before and after IV-GBCA. After 4 hours, we can see the enhancement of the meningeal lymphatics along the superior sagittal sinus. This is MIP image, and we can see the parallel line along the superior sagittal sinus. And this picture resembles like the original paper for the discovery of meningeal lymphatics using the animal study. And when we obtain these images, we noticed that after 5 minutes or 10 minutes, we see the tram-like enhancement along cortical vein. And this enhancement frequently spread into the surrounding CSF space. And also we noticed that in the aged subject, we frequently see this GBCA leakage into CSF space, but not in the younger subject. When we look at the 26 subject about the age and the degree of gadolinium leakage into CSF, under 37 years old, there is no leakage, and after that age, we always see the leakage. So we can say that the CSF in the elderly subject is a bit dirty. But when we increase the number of patients up to 190, we see some overlap or exception of these age threshold. This is a GBCA leakage negative group and positive group. Of course, the age of positive group is older, but there are some overlap. However, still the prediction of the leakage, the 37 years old is a good cut-off value. And we carefully look at this tram-like enhancement. We notice that this seems to be a like cast-like structure or some kind of sheath-like structure. So we searched for the anatomical basis of this morphology, and we found this a bit older paper, and in this pyrosis in the arterial side covers almost all lengths of artery in the brain. However, in the venous side, this pyrosis coverage is sparse. So the GBCA flowing out in the peri or paravenous space can enter into this pyrosis. And this is a schematic view, and this is subarachnoid space. The red blood cell exists only in the subarachnoid space. However, in the meningitis, inflammatory cells exist both in the subarachnoid space and subpyral space, including this pyrosis. The distribution of this inflammatory cell seems to be quite similar to the distribution of IV GBCA. So 3D real inversion recovery with IV GBCA might be an imaging biomarker for neuroinflammation. And first we look at the image carefully, and we notice that this tram-like linear enhancement directly connected to meningeal lymphatic vessels. And also we notice sometimes in this parasagittal area we see some cystic structures seems to be obstructing this subpyral cyst. And these cystic structures compressing sometimes the brain parenchyma and remodeling the inner table of the skull. And the number of cysts and the size of the cyst is larger in the GBCA leakage positive group. This is a paper from Korea, and they measured this parasagittal dura volume on the contrast enhanced T1 weighted image, black blood T1 weighted image, and they report that this volume of parasagittal dura is age dependently increased. This is very interesting. And this is a paper in Nature Medicine recently reporting that in the idiopathic Parkinson's disease, the meningeal lymphatic drainage is impaired. They serially scan the subject meningeal lymphatics area serially after the IV GBCA and found that the flow or contrast enhancement of this meningeal lymphatics is decreased compared to the normal control in the idiopathic Parkinson's disease. So in conclusion, waste clearance system of brain is a hot topic in neuroscience. Downstream part of lymphatic system, parasagittal dura, meningeal lymphatics, perivenous cyst might be important targets of research. In human, MR and IV GBCA will play an important role to reveal the mystery of lymphatic system. Thank you for your kind attention, and I hope the pandemic will disappear soon. Thank you.
Thanks, Dr. Naganava. So now let's move to the third speech. The third speaker is Professor Imak Heki. He's a very famous professor, and he's working in the Department of Radiology, Wayne State University in United States. And he's also the professor and vice chairman of Department of Biomedical Engineering of Wayne State University. And also he's also the first president of ISNVD. So his topic is microimaging as a means to study the brain's microvasculature in neurodegenerative disease. Welcome, Dr. Heki.
Good morning, good afternoon, and good evening, everyone. So it's my pleasure to follow these two excellent talks about the lymphatic system, which really requires a lot of very high resolution imaging and monitoring the uptake of the contrast agents over time. In this case, I'm going to talk about the vascular system per se, and not the lymphatic system, but perhaps one can use the results of this to monitor how the CSF surrounds and interacts with the vascular system. So I would also like to thank particularly Yongsheng Chen, Yulin Ge, and Dr. Sagar Buch, who's done a lot of work on this with us and is also here to participate in the discussion as well. So microvascular imaging stands for Microvascular in Vivo Contrast Revealed Origins, or MICRO for short. And it's a new approach to image all the vessels in the human brain that are 50 microns or larger. And imaging the microvasculature is key to unlocking the etiology of many neurodegenerative diseases, including dementia, hypertension, multiple sclerosis, Parkinson's, stroke, and traumatic brain injury, to name a few. But it's very difficult to detect in vivo small vessels less than 250 micron with conventional MRI, even with the use of, say, gadolinium, for example. However, if one looks at the veins, because they have deoxyhemoglobin in them, and uses a technique referred to as SWI, it's possible without a contrast agent to image vessels as small as 50 microns already. In this case, these are the venules, and this is a 7T data set, also courtesy of Yulin Ge, with roughly 200 micron by 200 micron in-plane resolution. So you can basically see vessels that are roughly 4 times smaller than the voxel, thanks to the combination of the bold effect, T2 star effects, cancellation effects that take place, and enhancement of the SWI image using phase data. So what we would like to do is to use an iron-based contrast agent to make the arteries look like veins. So if we can introduce susceptibility into arteries, if I can see 50 micron venules, I should be able to see 50 micron arterioles as well. So our goal will be to use high resolution to be able to get to as small a vessel as possible, so roughly 200 microns, use SWI to further enhance the signal, and then to post-process this signal to separate arteries from veins. And to do this, we use a low dose of pheromoxetol, an FDA-approved agent that's used for treating anemia. However, safety, of course, is a big concern. You don't want to inject these iron-based contrast agents quickly. You have to be careful that people don't have any allergies, low blood pressure, hemochromatosis, or thalassemia. Clinically, it's recommended you can administer up to 7.5 milligrams per kilogram in patients who are anemic over at least a 15-minute time period, along with saline. In our study, the maximum dose was only 4 milligrams per kilogram with 50 milliliters of saline used, and we administer this over 20 minutes. All subjects were monitored 30 minutes after administering the pheromoxetol. A nurse or physician was always present during these studies. And to date, we have done more than 60 of these subjects, and we haven't had any reports of effects at all. Well, this is an example of what you can see if you project over a little bit more than a centimeter in the brain using this concept of microimaging with pheromoxetol. And basically, you can see all of these small vessels. You can see the very small medullary veins here. You can see the very small 50 micron arterioles and venules. It's really quite phenomenal. Now, I'm not an artist. I can barely draw a circle on a blackboard, but I would have to say this is one of the most beautiful pieces of art that we've been able to collect in MR angiography. So here's an example now at 3T, a pre-contrast SWI and a post-contrast SWI using ferromoxetol. And you can see that it just brings all these vessels to life. And so you can follow all the patterns of the arterial systems and the venous systems. One can take this in 3D and we can reformat this into different orientations. This is the original pre-contrast magnitude image, which shows an MR angiogram, which we will then use also to try and separate arteries from veins. This is the pre-contrast SWI, and then this is the ferromoxetol image. If you reformat these into sagittal orientation, you can really begin to see now even the thalamic arteries are very well shown here. And any of you who may know George Salomon's beautiful work on cadaver brains, where he injects a dye to image either arteries or veins, you will see that this looks just like his cadaver brain work. In fact, many years ago, George was kind enough to send me an example of his data after he saw some of our SWI data here. And his comment to me was, oh boy, we can do this in vivo today. So here's an example of trying to isolate the major arteries from the major veins in this microdata. So you can see the veins are shown in blue. This comes from the pre-contrast data basically, and the arteries in red. And now there are basically three different levels of vessels here. There's the major vessels on the order of several millimeters. There's vessels that are on the order of maybe 250 microns to 1 millimeter. We call this the second level vessels. And then there are the third level vessels that represent the very small venules. And at the moment, we're working on techniques to try to get down to the third level. It's a very difficult process because there are so many vessels present in the brain. So one of the areas that we first started to look at because of our interest in Parkinson's disease also is to study the midbrain. And here's an example of the pre-contrast midbrain, the first image during the 20-minute injection, the second image during the 20-minute injection, and finally, the last acquisition after the injection has been completed. And you can see, we can begin to see all the small vessels that are in the midbrain. And this work has been published by Dr. Sagar Buch in NeuroImage last year. And I want to show you an example here of the cadaver brain work by George Salomon. You can see many of the defining arteries and veins in the midbrain. And these are 8 different normal volunteers. And you can see the general structures and even the location and general shape of these vessels is pretty much the same from subject to subject. So in many ways, I think the data that we've acquired here is just as good as the cadaver brain images of George Salomon. And I think that's extremely exciting because it opens the door to study microvascular disease. We've also done some quantitative susceptibility mapping with the same data so that we can see where the structures like the substantia nigra and red nucleus are relative to the veins. And if we overlay the vascular structures here on top of this, you can now see the arteries that are feeding the red nucleus. You can see the vessels through the substantia nigra. So it's a very exciting opportunity to be able to study any individual territory in its microvasculature. Now, maybe one of the more future exciting areas we've been looking at is actually to map out the vasculature of the hippocampus. So in this image, which I'm sorry is supposed to be a video here, but that's okay, we have extracted the vasculature associated with the hippocampus as shown here. And again, remember, this is 3D data. Here's a schematic of the vessels in the hippocampus. You can see here the vein in blue, the artery in red. Also here you can see many of the smaller draining veins coming into this larger vein. And if we look at the microimaging, you can see this wing-like territory here showing all of these same vessels draining into the vein. So here we have the major vein and here we have the arteries. So now we're looking at doing a map basically of the vascular density for the hippocampus and all the different subregions. And blue means low density, red means high density of vasculature here. So we're just working on this right now to write it up as a paper. But I think that microimaging really offers a tremendous opportunity to study many parts of the brain. I want to close with an example in multiple sclerosis. Multiple sclerosis has a vicious circle of events going on that relate to endothelial damage, venous collagenoses, fibrin deposition, loss of vessel compliance, venous hypertension, perfusion reduction, medullary vein dilation, local vascular remodeling, and ischemia. And so the question is, can we begin to see more of what is happening in the medullary veins? And you saw already that the medullary veins are beautifully enhanced using microimaging. The medullary veins have multiple territories, and there's an area called territory 2 here, which is also called the candelabra boundary. And that's because many of these veins come together like a candelabra here in order to drain into the center. And that's because the volume on the outside is much larger than the volume on the inside. And if we use microimaging to do this, we can clearly see the medullary veins. Sorry, that movie's not playing either. We can also extract them in 3D quite easily today. If we take the SWI data and marry it with the FLAIR data, producing something that we call SWI FLAIR, which other people have done with T2 star, you can begin to see that many of these lesions have what are referred to as central vein signs, but they also have a lot of other venous structure inside them as well. So the question is, what's that going to look like with microimaging? Well, here's an example of pre-contrast data to see what happens in terms of enhancement. And you can see a small enhancement of this lesion. However, when you use microimaging, you can see that there's a small developmental venous anomaly in this lesion. And the venous anomaly itself actually defines the boundary of this lesion, as you see in the FLAIR data. Now, this is not seen in all lesions, but we do see it in multiple lesions where we have vascular showing very clearly here. So I think using microimaging to study the microvasculature of MS is very important. And for another reason, if one looks at the central vein sign and uses very high resolution, we can begin to see these small territories abutting the boundaries of the veins. These are small white matter enhancements that are generally not seen with conventional lower resolution imaging. And you can see that these are abundant in the MS patients. So I think this is going to be a very important new way to study the presence of abnormalities and perhaps begin to look at the question, is this an inside out theory for the damage in MS or outside in? Inside out meaning that there's an endothelial damage, there's a leakage here of cytokines and other destructive proteins that cause inflammation around the border of the vessel. So this is just something we're only beginning to get experience with at the moment, but I believe micro opens the door to look at this more carefully. Just in closing here, we've also done this with some tumors to look at the microvasculature of tumors. And one of our long-term goals is to also do this to look at the structure of elderly patients and see if in dementia, the normal straight vessels start to become corkscrewed like this. And that usually means reduced perfusion to that territory. So these are all things that remain possible with microimaging. And I think it offers the ability to unlock the etiology of many neurodegenerative diseases. It can be done at 70, but of course, I just showed you it can now be done at 3 Tesla. I think micro brings us to the decade of imaging the microvasculature for the entire human body. And perhaps studying the lesions in multiple sclerosis using micro will open some new doors to understanding the process. Thank you very much.
Thank you very much for the great lecture, Dr. Hecke. So after the 3 lectures, it's time for the questions and discussion. And Dr. Lucas Mueller will be in charge of the panel discussion and collecting questions from the audience. And I'd like to have a brief introduction. Dr. Muller. Dr. Muller is the assistant professor in Department of Mathematics of University of Trento in Italy. So welcome, Dr. Muller.
Thank you very much, Dr. Wang. The panelists for this discussion session, two of them we already know because we have Professor Yulin Yi and Professor Wang. So they do not need any kind of introduction. And then the third panelist is Professor Alan Tannenbaum, Distinguished Professor of Computer Science and Applied Mathematics at Stony Brook University. And there have been many questions for Professor Benveniste in the question and answer box. Many of them were diligently answered by Professor Benveniste during the other talks. We still have a couple of open questions. I don't know if we want to start with that. I don't think we need to address the questions that were already answered by Dr. Benveniste. So the ones that are still open regard one is for Professor Benveniste, and it's by Ryan Temmel, and it's about the question reads as follows: do you know or would you expect atherosclerosis in the circle of Willis or carotids to disrupt lymphatic fluid flow? My group is working on monkeys that develop extra and intracranial atherosclerosis. Could lymphatic fluid flow be measured in this animal model?
This is a really good question and very pertinent, because we have been working in the Ledoux Transatlantic Network with Dr. Wardlaw's group and Dr. Black's group on different animal models with several small vessel disease and also hypertension. So when we look at these, let's say, spontaneous hypertensive rats, really chronic hypertension, we do indeed see that the flow around the circle of Willis is impeded. And sometimes actually we see more vasculature in this area. And I think that is sort of the phenotype, at least in the preclinical arena, that it does impede, the cerebrospinal fluid dynamics into the system. So at least from our data, and also think from Dr. Nedergaard's data, in preclinical models, the lymphatic flux is actually only reduced in these models by 20 to 15%. So it's not like in severe Alzheimer's models, but it certainly has an impact. And stiffness, the vascular stiffness, is clearly affecting cerebrospinal fluid flow in this area. Very important question.
So thank you very much. Just now, one question before I leave the word to the panelists. One question for Professor Haki by Ben Inglis, and it's Mark. The message reads: Mark, stunning images. How much does normal variation in arterial tone, for example, from variations in PCO2? Okay, it was just answered.
Well, maybe I can answer that a little bit for the whole public, because I only sent that to Ben. It's a very good question Ben has. There can be cardiovascular pulsations that take place, and you might ask, how can we be visualizing small vessels that are 50 to 100 microns if there is slight motion or pulsation, given that this takes 5 to 10 minutes to collect this data? The reason for that is that we're using 250 micron voxel sizes. And so the reason we see these vessels is because of the significant T2 star signal loss that takes place. So even if that vessel moves around a little bit within that 250 micron voxel, it's still going to cause that dephasing effect. And so, we can't measure the size of these vessels. I can't tell you that it's 50 microns. I only know from anatomy that they're 50 to 100 microns. But our ability to see them appears to be unaffected, as you can see in the example I showed with the 8 different volunteers in the small vessels of the midbrain, we consistently see those vessels in everyone that we do the scanning with. So generally, unless there's been a major motion of the brain during the scan that would blur everything, we're still able to see these small vessels very well.
Thank you, Professor Hacke. So now I think I will turn the word to the panelists for comments or also for direct questions to the speakers.
Okay, so sorry. So okay, I have to say, all great talks, and I have questions for Dr. Dr. Hacke and also Dr. Benveniste. So regarding, Dr. Hacke showed, the great work on the microvascular system, and Dr. Benveniste showed the, the great work on the lymphatic system. So how do you combine? Can you give us, some comment, a brief, for the future, for directions, how to combine these two systems, how to, in terms of, the technique wise, how to detect, because this is kind of important to better understand the brain, the clearance system from the blood to the CSF, and kind of the general overview of this system, how to combine these two. Thank you.
Well, maybe I could make just a comment about the imaging part, and Helena can comment on how to marry the functional part with it. So I think we could redesign the acquisition of the microimaging or collect just a second data set that would enhance the CSF. We can actually do this by using a technique called stage that will basically let us pull out the CSF completely at the same resolution we're doing the vascular imaging, so we could overlay the vessels on top of the CSF. And when you do that, I think you're going to see that there's CSF around pretty much every vessel. I don't know about the 50 micron vessels, but pretty much all vessels will have CSF surrounding them. So then you would have a really beautiful map of CSF and vasculature together. Now the question is, how can we monitor what happens between those two systems? Maybe Helena can comment on that.
Well, this is a very difficult question. I can see also there's a question from the panel about, the iPad, which, is a very relevant concept here, and why am I not discussing this? Why am I not discussing exactly how, the molecules, when they enter, actually go to perivenous channels, or at least or do they go to periarterial channels? The fact of the matter is that we really don't have, the spatial resolution, at least in our data, dynamically to answer this. And the very high resolution data on the 2-photon side, for example, does not capture the whole system. So we really need to be open, I think, to both concepts, about the periarterial drainage versus perivenous drainage, especially as to how things get out. And I think just a comment, looking at the trickle of tracer moving to the cervical lymph nodes along conduits that are, at least in our setting, involving the neck arteries. We have to go back and think about it. There are also arteries in the meningeal. The meninges has a middle meningeal artery that on both sides we have lymphatic vessels. This is data from Alitalo and Kipnis. I mean, these are arteries. So, and the lymph is draining along them. So I think we need to put all these together eventually, but the techniques that we have are limited. So it's not like I'm opposing this or that. I'm trying to follow my data. Another good question that came up was about the validation, let's say, of velocity flux. Is it fast or slow? Everything I mentioned is relative, right? So we need to have numbers on these things. We need to be able to, go from the animal to the human, bed and marry all these concepts. But right now, I think we have more questions than answers. But I just want to get this out there that it's not that I'm saying perivenous or periarterial, because I think the only thing I'm pretty sure about is that when we see flow go into the brain, it looks like it's periarterial. I'm not really saying anything about the perivenous drainage at this point because we can't see it. I wish we could see medullary veins like Dr. Hackett is showing. This would be wonderful. So this is all I can say, and I apologize, but I don't have the answers.
Can I ask a question to Dr. Hackett as a panelist? Am I pronouncing the name correctly? Hackett?
Hakey.
Hakey, sorry. I had a PhD student named Haker, and people would call him Hacker. So I know it's a sensitive topic if your name is that, Hakey. So Dr. Hakey, very nice to meet you, and those are really nice images. You mentioned before that you wanted to apply this to tumors, I guess GBMs, which of course is it's another great interest of ours, because I guess you want to investigate the margins for better surgical techniques. So how far has that gone? I know there would be people very, very actually interested in this who do various techniques. They're using imagery at the time of the surgery, for example, at the Brighams. So how far have you gone in this? I mean, the images really look nice.
Yeah, I can let me, before I answer that question, let me just comment on the slide I showed you. Those were metastases. And the interesting thing about those is some of those lesions have uniform vascular distribution, but there are many of the lesions on that individual that have an annular ring of blood vessels. So you would find a dramatically different tumor structure here. And as those small lesions grow, the annular ring, it's like a snake of blood vessels surrounding the lesion. And as that lesion grows, there's almost no vasculature left inside. It's all on the peripheral. So it seems to me there are some very different growth patterns in these tumors. And we're only really just beginning to do that. So Alan, I'd be happy to share some things with you about this. If you'd just like to send me an email, that would be great to talk to you about it.
Absolutely, because I'd like to share with you some things on tractography, etc., which is all connected. So you're at, so Dr. Hakey, you're at Wayne State University?
Yes,
so I can
that's
write
right.
you?
I'll just send my email to you here, okay?
That would sound great. That sounds great. Thank you very much.
So we have a few more questions. Should we address them or invite the speakers to answer via text in the interest of time? I don't know what the chairman, just because we're a bit behind schedule. What do you?
I think it probably is better for the speakers to reply individually.
Okay.
Because we kind of behind schedule.
Yeah. That's what I wanted to point out. Yeah. Okay. So I think we can hand the word to the next chairman for the next block of presentations, Professor Zamboni.
Thank you, Lucas. It's my pleasure to introduce the second section of this super interesting webinar of the ISNVD. The first speaker that I would introduce is Andreas Lininger, is of the Department of Neurosurgery, University of Illinois at Chicago, United States. And the talk is experimental and theoretical study of Solute dispersion in the cerebrospinal fluid. Please, Andreas.
Can everybody see my screen?
Yes.
Yes.
Okay, well, thank you for introducing this presentation, which goes in the direction of quantification by using experimental and theoretical methods to quantify the solute dispersion in the cerebrospinal fluid. This is work by my student Gen Gierke in collaboration with me. And my disclosures. As you know, the blood-brain barrier is a formidable obstacle to many large molecular-sized drugs, and therefore it is necessary in some indications to bypass the blood-brain barrier with invasive methods. These include interparenchymal delivery with a catheter, where you perforate into the brain tissue and discharge with a catheter the drug directly into the tissue. Can also use an Ommaya reservoir and basically put that catheter not in the tissue, but into the ventricular spaces and conduct interventricular or intracisterna administration. Today, I will be looking at intrathecal delivery, where the catheter is also placed invasively into the CSF of the lumbar region typically, and from that lumbar region, solutes or pharmacologically active agents are dispersed, and therefore also the blood-brain barrier is bypassed. The intrathecal drug delivery has been used for more than a century in chronic pain management, using morphines or other opiates for chronic pain management. And in the late 80s, my colleague Dr. Penn started using drug pumps and baclofen to treat spasticity. So again, an intrathecal administration was performed and showed that not only was the drug active in the area of infusion, but also dispersed along the neuroaxis. It was a result of a slow injection rate and low injection volumes. And therefore, there is some interest now into using drug delivery through the intrathecal space. But the question is how to set these parameters to achieve a desired distribution. So it has been the interest of my laboratory, and I need to slightly correct my affiliation. I'm an associate in the neurosurgery department, but I'm in the Department of Bioengineering, and I'm an engineer by training. So the intrathecal delivery administers drugs into the CSF of the spinal cord. So here we are looking now in a space vision of the spinal cord from the outside and penetrate into this CSF space, this narrow space between the dura in gray and the pial surface in pink. And in between you have this narrow gap space that is filled with CSF that is not static, but that is pulsating. And these little massless particles illustrate that pulsation. So we were curious about these flow phenomena in those spaces and the role of influencing factors such as the CSF pulse amplitude. And we went into the bench experiments to isolate these phenomena. I know this is a practice that is not used by many colleagues in medicine, but this is the way engineers think. They want to see the phenomena in isolation and then piece them together one by one. So as to being able to quantify these phenomena. So we started with SPECT imaging of a radionucleotide in a pulsating flow. So we built a surrogate model, a very simple one, where we put two tubes together, one with a pulsation like we see in the spinal cord, and one with a stagnant fluid. The objective was here to isolate the effect of pulsation on the dispersion. And I showed these rather old images. Because it was for me a revelation to see that when we do side by side this experiment with a column that is stagnant and another column which has pulsations, but these pulsations have a net zero flow. So the pulsation go in the craniocaudal direction and in the opposite direction, but on average, these velocities cancel out, they are on average zero. So one would expect maybe that even though the fluid moves, there is no effect on the speed by which the tracer is dispersed. And we just saw the opposite. So the tracer is dispersed much faster in the pulsating fluid than it is in the stagnant fluid. So a few generations later, we have systematically made those experiments. Let me see, the animation seems to be asleep here. Let me see if I can bring that back. Yeah, I should have animated. Sorry, the animation is kind of falling asleep. I hope you can still see. Here is basically an experimental matrix visualized dynamically, where we have the effect of infusion volume, 1 milliliter, 10 milliliters, and 20 milliliters over amplitude of CSF pulsation from very low pulsation of 40 beats per minute to 72 beats per minute to 120 beats per minute. As you can see in the time-lapsed videos here, is that both the injection volume as well as the amplitude of the CSF pulsation have a strong effect on the speed and on the width of the dispersion of these tracers. So what we set about with these very simple experiments is to basically study the influence of those parameters on the achievable biodispersion of tracers. And what was invariably an important factor was we did here experiments in which we tried to mimic the microanatomy of the subarachnoidal space in the spinal cord, which is characterized by these nerve roots that protrude into the CSF space. And when we left those nerve roots out, the biodispersion was much slower than when we had models that mimicked these intricate microanatomical features of the spinal cord. So we concluded that the intricate space with microanatomical features protruding into the CSF was a significant factor in achieving wider dispersion of tracers. Another feature that is hard to see, or actually invisible in current imaging techniques, are the presence of trabeculæ, which are small filaments of about 8 microns in diameter. And you have here on the left a cartoon that visualizes 3D simulations of pulsations of CSF in the microanatomical features with nerve roots and the spinal cord, but without accounting for these trabeculæ. While on the right, you have the same pulse imposed that we see in MRI, but in the presence of these microns. Here we used 200 trabeculæ per cubic centimeters. And you can see that the velocity is increased with these micro anatomical features, which we believe also increases the mixing effects that we see in the spinal cord. So we have over the years refined the realism of these models. This is the last generation of what we call a 3D replica of the human CNS. Again, in engineering terms, the replica pertains here to the physics of the mixing. It doesn't have blood vessels, it doesn't have neurons, it is just reproducing as faithfully as we are able these days the 3-dimensional space and the pulsation. So it's functional in the sense of CSF pulsation. And it contains not a small fraction or open segments, but it contains the entire neuraxis from the sacral region all the way to the brain. And we have made this with deformable materials, so we are able to inject into them and we are able to transmit the pulse in the way that we believe happens in a biological system. So in this system, we have a head section where we mimic the expansion of the vasculature with a balloon. That's a very coarse model for the vasculature. But what we believe is significant is the expansion of the balloon transmits itself to the CSF pulsation in the spinal cord. And then we inject a catheter and we perform injection and follow the here trypan blue tracer so we can quantify the speed of this dispersion. So let me try and see whether you can see some summaries in time lapse because we don't have much time today. So you see the head section with pulsations, and then you see again our 2 experiments, one with a stagnant fluid and the other one with the influence of pulsations. You can clearly discern that the pulsations lead to micro-mixing effects that drastically enhance the dispersion of the tracer. This is not a perfect picture, but it shows you the formation of eddies and micro mixing patterns around these nerve roots. And we find that this is a significant factor that causes the dispersion of drugs. It is this intricate microanatomical features around nerve roots, which cause what we call geometry-induced mixing or chaotic mixing. And this is different from what you would expect normally at these low flow rates. In engineering terms, we call this low Reynolds number flows. But even though we have very low Reynolds numbers, we have these mixing effects that come from the anatomical features in the spinal cord. The benefit of this experiment is that we are able now to use the intensity of the tracer and quantify exactly the dispersion speed. So here you can see some images that show the dispersion of the tracer and the concentration profiles of the intensity of the light when we shine that through, which allows us to quantify both the mean and also the variance, if you want, the length of the dispersion in such a way that we can characterize the dispersion coefficient. And the goal here is to not only observe the speed for different experimental settings, but to basically correlate the dispersion coefficient to key parameters such as the amplitude of the CSF pulsation, the frequency of the CSF pulsation, as well as infusion parameters such as infusion volume and infusion duration. So I can summarize here only that the prediction of the diffusion coefficient based on these factors and the experimental one show a reasonable trend. So that gives us confidence that we can not only perform experiments with realistic parameters, but also predict the outcome of such infusion experiments. So we are using these quantitative data to make a decision-making tool that allows you to predict the pharmacokinetic effects of intrathecal drug administration. Mostly we're interested in the CSF distribution in the spinal cord, but there's also targets, for instance, for antisense oligonucleotides in the brain. So we're interested in CSF dispersion into the brain. And then obviously the targets are not the fluid, but they are tissues. So we have spinal cord tissue or we have brain tissue to treat. And therefore the targets are here depicted in orange. In this pharmacokinetic model, we want to be able to predict also the amount of drug that reaches these tissue areas. I'm focusing here just on the central element, which is the CSF distribution of spinal cord in the brain. And by using the experimental data, we can use a very simple model that is basically similar to pharmacokinetic models that are used in practice already, but that has the main difference that we propose here, that the central spinal canal is a distributed model, not a lumped model. And therefore we can propose here a model that I don't want to belabor in this audience too much, but it is a model that has the convective diffusive element, an element for dosing, potential reactions that I didn't show in my experiments, tissue exchange and uptake into the tissue. But basically, in a nutshell, we can use our engineering methods to convert the lessons learned from the experiment into an active quantitative practical tool to predict the dispersion of drugs that are injected into the spinal canal, but also how much drug would reach different compartments such as the brain tissue or the spinal cord tissue or be lost by uptake into the epidural fat. So here are some typical results of this drug dispersion model. The key result here is maybe the ability to predict for long time periods, so not only a few minutes or a few hours, but we'll be able to predict the fate of drugs for several days, which is important for very long-lived molecules such as ASOs, where they may have a half-life of weeks or even months. So in this long-term model, we are able to look at the infusion parameters, which is very important because these are the strongest factors that you can influence. The CSF pulsations and the CSF frequency is very difficult to manipulate, but you can manipulate your injection protocols by using one or more injections and then cause effect on the dispersion of the drug that is directly influenceable by the infusion. And the model is able to show you the dispersion in these different compartments. Maybe as a intuitive overall message, I would like to say that there's two competing phenomena. One is the natural mixing. This is the physical mixing around those eddies that I described. So you start out here with a very narrow profile of the injected drug at the injection site. And then by natural mixing, it is basically widened and has also a certain tendency to reach into the groundocranial direction, because on the sacral region, the space is closed. So you have this motion from the injection site towards the brain. But in addition to that, and that was not visible in my experiments with the tracer, you have interaction of the molecules with the spinal tissue, especially lipophilic drugs are uptaken. So it's possible that instead of being able to reach very far away from the injection site, it's possible that the drug gets uptaken in the tissue right away. So even though it would normally mix, because of its interaction with the tissue, it doesn't go that far. And this is what we have seen a lot in the practice of the past. People have used very, very low infusion rates with drug pumps, for instance, and they have used very readily uptaken molecules. And then they concluded that one cannot really achieve very wide biodistribution in intrathecal delivery. And that was actually the case in their experiments, because they used very low infusion rates and they used very lipophilic drugs. And in that sense, they achieved only very local distributions. We, however, know now that this is only the case for the parameters that they chose. And if we choose different parameters, we get much wider distribution. For instance, here we did some experiments in collaboration with people in industry with signal monkeys. So here we did a study in which we used 5 animals. We carefully acquired the CSF pulsations, and we used PET scanning to track a labeled molecule. By feeding these CSF data and the biomechanical data of size and pulsations of the CSF into the model, you can see here there was not a perfect, but a reasonable agreement between CSF measured in vivo and CSF predicted by a 3-dimensional dispersion model. You can see the dispersion model is also able to reproduce those mixing eddies. And by feeding that into a model that is similar to the one that I showed before, but now here in 3 dimensions, we are able to predict the dispersion and compare it to the actual dispersion that was seen in vivo. And we get some agreement here that is illustrated here with the R-square value. And I have here the comparison between the CSF flow and tracer distribution in the animal experiment and in the simulation. So we are confident that we can basically predict the correlation between these infusion factors and the outcome that we see. So in conclusion, the factors that influence intrathecal drug distribution have been known somewhat intuitively in the past, but very crisp correlations have been absent. We have now been able to characterize those and quantify those factors to make predictions, if you want, engineering predictions of how to design intrathecal drug therapies. These we group into patient-specific parameters such as CSF volumes, possibly anomalies that a particular application has for treating a pathology. And a key factor was the CSF pulsations, amplitude and frequency. Infusion choices, which is what you can influence, is infusion rate and volume, patient posture, and the design of the catheter. These are the parameters where you have the most influence. And this is, I think, where currently there's a lot of interest in the pharmaceutical industry to kind of be guided in their trials with not just experiments on animals, but also with these kind of new quantification techniques that, such as the one that I propose here. And then the third parameter, which is significant for the biodistribution, includes reaction kinetics and lipophilicity. So here I show results again from these 3-dimensional models. These models we use for very detailed studies, for instance, of these mixing eddies that occur around the micro anatomical features. Or, for instance, we are able to even give answers as to particular positioning or design of catheters. So here we solve the flow field and also the mixing patterns around these ports of catheters or drug pumps, and are able then to make informed recommendations about which catheter or which infusion rate would be successful for a particular therapeutic target. So that takes the trial and error experimentation out. And for all of us who have made experiments with intrathecal delivery, these experiments in animals or even worse in human are not really fast to do. They're very time intensive. And so the computational effort is hopefully giving informed decision support that is faster and also reproducible. Yeah, I just show a final slide of the same drug injection, but the effect of reaction kinetics. These are three different molecules, morphine, afentanil, and sufentanil. They are injected exactly the same way in this study, but they show completely different uptake in the spinal cord tissue based on their lipophilicity. So morphine has this uptake here. Afentanil is much more confined to the is much readily uptaken in the spinal cord, and sufentanil has a completely different uptake profile. So this shows that the chemistry of the biochemistry of the drug is another important factor that we are able to quantify. So in conclusion, intrathecal drug delivery has in the past been deemed to be efficient only for local delivery. Our experiments and our in vivo studies show clearly that high volume bolus and injection volume are able to achieve much wider distribution as written in the classical literature. The classical work has often been done with drug pumps that have a very low infusion volume, in which the dispersion is mainly driven by natural pulsation. So you don't get anything from the injection itself. The drug uptake, as I said, can also slow caudocranial spread, and the early studies, as I said, that were done on pigs, for instance, they have used very low infusion flow rates and very high uptake drugs for targeting the head. That would be not an ideal choice, and we can make better choices using high volume injections. And what I tried to show is that now computational models that are being developed are able to use patient-specific data and predict drug dispersion inside the spinal canal that agrees with clinical observations. And computational models can be used to design and to optimize treatment parameters for safe and efficient intrathecal delivery, and maybe for shortening the cycle to get from a new drug into a safe and efficient application. I added some references for people who are interested to read about this, and I thank you for your attention.
Thank you very much, Professor Lindinger. A great presentation. Now we move to a co-presentation on behalf of Professor Hugo Tenkate and Professor Henry Spronk from the Cardiovascular Research Institute of Maastricht and from the Thrombosis Expertise Center of the same university in the Netherlands. Blood composition and physical properties in perfusion and in COVID-19.
Thank you very much for this kind introduction. First, let me try to share my screen. Hope that's clear for everybody. Assay, thank you very and thank you very much for this kind introduction and the opportunity to present, also on behalf of Hugo Tenkate, which unfortunately could not attend this meeting due to an urgent appointment with the Dean of our faculty. So that's the first apology to make. The second one is that I have no topic on neurology, neurofluids. I have some on methods and disease, and I still hope you can appreciate that. Having said that, I come from the area of hemostasis and thrombosis. I'm trained as a biochemist in hemostasis, the coagulation system, which classically looks at the processes involved in the stopping of a bleeding. But that also involves when it's a pathological process, the thrombosis, and mainly are known as the arterial thrombosis occurring in the heart and the brain, as you all might know, as well as the venous thrombosis. And what we normally would like to stress, to point out, is that 1 in 4 deaths worldwide still are due to thrombosis, especially now in the area of COVID-19. The figure from the NHO or the NWO from 2016 was 15.2 million people suffering from thrombosis and the resultant of that. So that's some number to take into account. That's not my main area. I shifted over the past years to the what we call the pleiotropic effects of coagulation enzymes. We see here a simplified and cascade starting from the tissue factor 7A, going to factor 10, a thrombin formation, and finally fibrin formation. And what has been studied since the early 2000s is that these coagulation enzymes, thrombin and factor 10A, also can activate certain receptors, the so-called protease activatable receptors, the PARs, on a variety of cells, and thereby influencing processes such as apoptosis, inflammation, fibrosis. And the area we were mainly focused on was on atherosclerosis and atrial fibrillation, showing that activation of these PARs leads to enhanced atherosclerosis. And if you inhibit the enzymes, thrombin or factor 10A, you can diminish atherosclerosis. And that's maybe the link to NEUROFLUIDS, is that we now more and more learn that these small coagulation cascades that are present inside the atherosclerotic lesion are also present in the brain, and we're shifting a little bit more and more to cell signaling induced by coagulation of the astrocytes, pericytes in the brain, and learn how to learn how that influences neurodegenerative diseases. So that's where I normally come from. That's not the main topic. I would like to focus for this presentation on the thrombosis risk in COVID-19, quite familiar to all of you. And to be honest, a year ago, I would have been as I last week explained to colleagues of mine, that a year ago I would have presented the coagulation, the hemostasis, as an arrogant biochemist, knowing everything about it. But thanks to COVID-19, I'm back on the ground with 2 feet, because we simply don't know what's going on. You all have heard, most likely, that the critically ill patients with a COVID-19 infection show hyperinflammation, vascular damage, and a coagulopathy with high rates of thrombotic events. If we dissect that a little bit, the first publications in 2020, early 2020, showed that the majority of non-survivors showed symptoms of the disseminated intravascular coagulation, meaning that the clotting system, the coagulation system, is so much activated that all coagulation factors are consumed, and thereby inducing a bleeding risk, although the bleeding risk is hardly seen in these COVID-19 patients. So therefore, I'm still in doubt whether it's a classic coagulopathy process or that's just the thrombosis part. A couple of weeks later, we got the first evidence that the coagulation system is hampered by increased markers of fibrinolysis, the D-dimers, marker of fibrin formation. We saw a decrease or shortening of the prothrombin time. There was an increase in the activated partial thromboplastin time, and that was later confirmed by showing also altered prothrombin time and D-dimer levels on admission of patients into the ICU units. Overall, 1 year later, we now see that for patients on the intensive care unit, we see an incidence of venous thrombolic complications of roughly 60%, whereas the general admitted and hospital patients show only 10% venous thrombolic complications. To put that all together, we have to understand how the coagulation cascade works, how it is all combined. There are all the coagulation factors that finally lead into the formation of thrombin, the main enzyme in the system, activating or converting fibrinogen into fibrin, activating the blood platelets, and that all together leads to a fibrin clot together with platelets. In a more simplified scheme, we now know that the main activator of hemostasis of the cascade is vascular damage, where subendothelial tissue factor is exposed to the blood. That activates factor 7, factor 10 is involved, and we get thrombin. In the same way, vascular damage leads to exposure of subendothelial collagen fibers, activates platelets from a resting state to the activated states, and together with fibrin, that forms a thrombi, or in the case of a bleeding, just a blood plug to prevent the bleeding. We also know that, whereas we didn't know that in the past, that the intrinsic activation, so the factor 12 activation, is activated by pathological triggers such as polyphosphates from platelets, collagen from the vessel wall, and the new discovered one, or a couple of years old now, the so-called neutrophil extracellular trap. And in COVID-19, there is evidence that viral infection leads to this NETs formation, thereby activating the coagulation system. But if we go back to the initial presented data, we see that the prothrombin in some papers is either prolonged, or in other papers it is shortened. The APTT is prolonged, which we don't know. We see higher levels of fibrinogen. We see elevated levels of D-dimers, suggesting that the coagulation cascade is activated. We see increased activity of platelets, as well as very high numbers of platelets. Factor 8 is higher in these subjects, in the ill patients, most likely due to endothelial activation. And remarkably, patients have a kind of heparin resistance. It's not the correct word. What I mean with the heparin resistance is that the majority of ICU patients need the double therapeutic dose of heparin to lower the risk of venous thrombosis overall. But the problem with all these measurements is that they never ever were invented to predict or to demonstrate a thrombosis risk. For instance, the prothrombin time was developed in the 1940s to measure the vitamin K deficiency or vitamin K antagonist function, like warfarin or other derivatives of that. The APTT is classically used to show heparin treatment, and it is a sensitive method to show factor 8, 9, 11, or 12 deficiency. For the platelets, we have the light transmission aggregometry, which is useful to detect defects in platelet receptors like GP1B and GP2B3A, and is sensitive to antiplatelet therapy like aspirin or the ADP receptor antagonist, just like clopidogrel. Overall, these are assays to measure sensitivity for bleeding or a higher bleeding risk, but never ever for thrombosis risk. And that's why we, over the past years, are shifting more and more towards the global hemostatic assays, of which on this slide 2 are presented. On this side, the peak for the thrombin generation assay, which is a method in which plasma is activated by a trigger, for instance, tissue factor, and then thrombin formation in plasma is recorded in time showing a start of the coagulation cascades, which is more or less equal to the prothrombin time or the APTT. We then get a propagation phase and a termination phase depicting how much potential a certain blood or plasma sample has to generate thrombin. Problem with that method is that it still lacks the platelets and the other blood cells like white blood cells and red blood cells, and therefore we can have a look at the rotational thromboelastometry, which looks as the viscoelasticity of blood with after a certain trigger provided to the blood forms a clot. What this method does, in this case the ROTEM, the rotational method, there is a pin in a cup placed in the cup, contains the blood sample with the red blood cells, the white blood cells, the platelets and the plasma, and this pin is oscillating under a certain angle, so not fully spinning but back and forward. And once the clot is formed, the thrombi is formed, the fibrin is present, the movement of the pin alters and that signal is detected, and that is then depicted in a cigar, as we call it, in symmetry because the pin is oscillating to both sides. We see the start of the clot formation, like the thrombin generation equal to the prothrombin time or the activated partial thromboplastin time. And then we see an increase in clot firmness to a maximum clot firmness. And if we follow the classic example in time, there is a decline, and that is due to fibrinolysis, the breakdown of the fibrin structure. This is a very sensitive method, as these examples show, for bleeding or non-bleeding. I would like to put your attention only to this part of the data. This is the normal wave or cigar shape we see if you activate with tissue factor. In case there is hyperfibrinolysis, so an excessive fibrinolysis breakdown of the fibrin clot, we see that there is a decline in structure in clot firmness after a certain time point. In the case fibrinogen is absent, we don't reach the maximum amplitude, we only go a little bit higher. If the platelets are reduced, if there is a lack of platelets, the shape doesn't reach its maximum amplitude. And in the case of hypercoagulability, so an increased risk for thrombosis, we see a shortening of the time to start of the shape, and we see an increase in elevated levels. Due to time, I skipped the previous one. If we then compare a healthy volunteer on this side with the classic fibrinolysis present to blood of a severe COVID-19 patient, we see that there is a really increase in amplitude. It's a really higher level. And the initial ideas here were that this was due to the high fibrinogen levels. In our institute, COVID-19 patients have a fibrinogen level far above 9 grams per liter, whereas the reference range is somewhere around 3 to 4 grams per liter. Since we measure here fibrin formation, higher levels of fibrinogen would explain a higher amplitude in this case. On the other hand, the patient in this case is treated with a double therapeutic dose of heparin to reduce thrombin formation, and that would suggest that the curve would be way much lower, even prolonged in start. And that was puzzling us a bit because we saw that over and over for every patient. And therefore, we first set up an experiment with healthy volunteers, for which we measured the ROTEM data depicted in green and presented as the clotting time, so the start of the curve, and the maximum clot formation, so that is the amplitude which is maximum reach. There are some different parameters like the clot formation time, the time that's needed to reach the maximum clot firmness, and time that's over depicted here. And what we then did, we spiked or we added to the blood of the healthy volunteers, we added an heparin in two N-types, the unfractionated heparin and the LMWH heparin, so the shorter fragments. And it happened what we expected, is that we get a prolongation of the clotting time because the thrombin is, or the thrombin generation is delayed, so the clotting time prolongs. If we added also to this whole blood 9 grams per liter of fibrinogen, we saw hardly any effect on the clotting time, but as expected, we saw an effect on the maximum clot formation. Because there is more fibrinogen present, there can be more fibrin formed, and therefore the maximum clot formation increases. If we then did the combination of fibrinogen with an unfractionated heparin or the combination with the fractionated one, we saw that due to the higher level of fibrinogen, the clotting time reduced back to normal, but not in the case of the combination of fibrinogen and heparin for the maximum clot formation. So the clot is still formed, but with a reduced time. The next question then is, of course, how does this compare to the COVID-19 patients? But before I show that, we were not quite happy with these results because it couldn't explain everything. And what we therefore did is we came up with the idea of looking at two new parameters in the ROTEM data, so in the cigar shape, and that is to calculate the slope from the beginning of the curve to the 20 minutes time point, so the slope CFT, or the maximum slope formation time, and compare those. And when we did that for the healthy volunteers, that are the two bottom figures on the right side, at least on my screen, we saw again that heparin didn't have much influence of those two parameters as it did on the maximum clot formation time. Now going back to the COVID-19 population, which are depicted here, and compared to the healthy controls in green, we see in brown the COVID-19 patients. We see that the clot formation time, so the CFT, is for the majority of COVID-19 patients quite normal. There are some extensions, but the maximum clot formation is really elevated in the COVID-19 patients. If we then look at the two new parameters, the slope to the clot formation time and the slope to the maximum clot formation time, we see that the COVID-19 patients have a profile more or less comparable to the healthy volunteers. Whereas one would expect, due to the high fibrinogen and the presence of the double dose of therapeutic heparin, that they were more on the level of the aqua blue plotted bars instead of being comparable to the healthy controls. Overall, and in summary, healthy volunteers are depicted in this graph in green. That's the slope for the healthy volunteers. And adding 9 grams per liter fibrinogen to these samples in combination with the double therapeutic dose of heparin, we get a way much faster or steeper slope to the clot formation time and the maximum clot formation time. Whereas in the COVID-19 patients, it's comparable to the healthy volunteers, not explaining the thrombotic risk in these patients. So overall, we are still puzzled where the thrombotic risk comes from in these COVID-19 patients and whether even the double therapeutic heparin dose can solve this problem. And with that, I'm happy to take any questions and like to thank all the co-workers helping in this process as indicated on this slide. And if you would like to have more information, feel free to contact me on the email address depicted below. Thank you very much.
Thank you very much for this excellent presentation. Now we move from the last presentation of the second session. It's from Professor Toro. Is professor at the Applied Mathematics Laboratory, DICAM, at the University of Trento in Italy, and is also emeritus professor of mathematics in the same university. His speech is Mathematical Modeling of Craniospinal Fluid Dynamics, Progress and Challenges. Thank you, Tito.
Thank you very much for the introduction, Professor Zamboni. Can you hear me?
Yes.
Okay. So this is a joint work with my colleague Lucas Miller and PhD students Morena Celant from the Department of Mathematics at my university. So the motivation for this work naturally neurological diseases, and we all know there are many of them, but the main ones are Alzheimer's, Parkinson, multiple sclerosis, and so on. Neurological diseases represent a very strong burden to society, and here in this graph you see the role that neurological diseases play in quantifying the burden to society. Now, when it comes to studying these conditions, we have a situation that the causes are unknown, and therefore there is no cure, but of course there are treatments aimed at ameliorating and mitigating the disease, and some of the treatments can be quite successful in doing that. There is agreement in that the dynamics of fluids in the central nervous system plays an important role. And that being the case, then the whole field of research becomes very much an interdisciplinary research. Now, recalling the fluids in the central nervous system, I'm pleased to say to Professor Sprong, of course, that blood plays an important role. Here we have the vasculature at the top, here the arterial part, the venous part, the microvasculature in between. We have the interstitial fluid, we have the cerebrospinal fluid, and we have the peripheral lymphatics. Obviously, now also one needs to add the meningeal lymphatics discovered 6 years ago. And all these fluid systems are connected anatomically and functionally, although the precise connections are not necessarily well understood. Now, the venous system in particular is something I will address in the next couple of minutes. It has seen a resurgence of interest in this particular compartment, and part of that resurgence is due to the work of Zamboni in 2009 and Dr. Heike and many more people, indeed. Now, briefly, the venous system here in the full body, it has some particular features that are important to recall. It is the veins are collapsible. You can see a graph here in which you have pressure against cross-sectional area here. When the pressure is large, they resemble more arteries, but then as the transmitter pressure begins to be reduced, you see a collapse of the system. So veins are very deformable, highly nonlinear, and this places a problem, a challenge to mathematical modeling to begin with. Some classical functions of the venous system, of course, we have obviously returns oxygen-depleted blood to the heart, a major role in clearance of metabolic waste, and this is topical these days. We have heard the concepts of this kind in the previous presentation. The venous system is sync, obviously, not only to arterial blood, but also to ISF, CSF, and lymph. It holds about 70% of blood volume, and therefore, by the sheer volume, it plays a major role in the CNS dynamics. And there could also be a role in the lymphatic system discussed in previous presentations in this workshop. Now, the venous system has a prominence in some neurological conditions, for example, idiopathic intracranial hypertension patients, for example, the condition may well be related to malformations of the venous system. Here, what we see is a comparison between a healthy control venous vasculature here that you can see very nicely, and that of the patient here on the left. They are vastly different, of course. There are diseases associated to anomalous venous systems. Intra and extracranial venous anomalies play a role. And in the last 10 years or so, there's been an increasing number of works actually reporting this connection between the anomalous venous system and some diseases of the central nervous system. Idiopathic intracranial hypertension is obviously one of them, multiple sclerosis. In ophthalmology, the venous system plays a major role, and so on. And lately also in some form of Parkinson's disease has been reported. Interestingly, at least from the point of view of mathematical modeling, which is my field, the venous system has been largely ignored. And I must say that this ignored venous system has motivated my research for the last 10 years or so. There are some advances in this field, again, in the last probably decade. Here we have the IPAT system. We heard about this earlier. We have the Meningeal Lymphatics discovered at the same time, but two groups in 2015. This is indeed a very important discovery. Then we have the lymphatic system, of which we also heard during this workshop. And there is also the suggestion that the venous system may play an important role in the lymphatic system, given that from the perivenous space here, you may have transport directly into the venous lumen here of solids and fluid. Now, mathematical modeling, which is the main part of my presentation here. This is something that we began 10 years ago with who was then my PhD student, Lucas Müller, and we published the first paper in 2014. And we constructed a mathematical model that has some features that are important to point out. First of all, it is global. So it covers the full body here. And in that way, you avoid boundary conditions. It is a very important issue when it comes to mathematical modeling. So we have the arterial system here. We have the venous system, and all the bits and pieces that go in between, including the microvasculature, a model for the heart, naturally, the pulmonary circulation, and so on. For the head and neck, we have a more refined description of the fluids within the craniospinal part, which is the main subject of my presentation here. And so the current version of our model here will be submitted, I hope, in the next few weeks. And it is an important or very significant improvement of the model we published 7 years ago. One page only about the mathematics for this community here. One-dimensional representation of vessels leads to partial differential equations, which for a single vessel are stated here. You enforce principles of conservation of mass, balance of momentum, and the interaction between the flowing blood and the response of the mechanical response of the vessel wall. Naturally, our model is a simplified model of fluid extraction interaction because it does contain the interaction between the flowing blood and the response of the vessel wall. The vessels in our model are all compliant. They are not rigid. So the unknowns of the problem are the cross-sectional area of each vessel here, A, and it depends on where we are in the circulation, and it depends on time within the cardiac cycle. We have flow, we have velocity, and we have pressure. Now, pressure is a precious quantity because it's very difficult to quantify by other methods. And usually this method will be obviously invasive, and it's difficult to get data in the quantities that you would like to have from a subject. Now, we deploy advanced numerical methods to solve these equations on a computer. Now, the model then, and today we concentrate on the upper part of this picture here because it's about the craniospinal fluids here. But we solve the full system in the full body here. It's all coupled, so we compute flow, velocity, cross-sectional area, pressures, all in the entire network here. So for the head, apart from the vasculature here, the arterial part and the venous representation here on the right, we see, in addition to the blood, we also have the cerebrospinal fluid representation here. This is by adopting the model proposed by Lininger in 2009. And so we have representation for the cerebral subaryanoid space. We have a representation for the spinal subaryanoid space. We have the lateral ventricles, the third ventricle, the fourth ventricle, and the connection between these two, which is the aqueduct of Sylvius. And this is an important compartment because there is MRI, magnetic resonance data there, and therefore we can compare mathematical predictions with measurements. So this is a demonstration of the capability of the model that can model the interaction within the cardiac cycle of the arterial blood, the venous blood, the brain parenchyma, the CSF in the cranium, and the CSF in the spinal cord. So you can see here is a cartoon, obviously, but it is constructed on real computational data. So you see here the arterial compartment here, the total arterial compartment here, its behavior during the cardiac cycle here. As the volume of arterial blood that goes into the brain increases, you have to displace the fluid from other compartments here. So the coupling here between all the fluid compartments is fundamental to understand the dynamics of what's going on within the craniospinal compartment here. Here you see the spinal canal here taking some of the cerebrospinal fluid displaced during the cardiac cycle in the cranial cavity. Now, some comparison here. Are we computing the correct quantities? Because obviously mathematical modeling is something that you do from equations, and you solve these equations on computers using algorithms. But are you getting the correct reality? Are you getting reality? Are you representing reality? And so here we have a comparison between magnetic resonance data here and our computations in the aqueduct of Sylvius. This is flow here within the cardiac cycle. And here we have velocity during the cardiac cycle. Data from this paper here. More comparisons between magnetic resonance measurements here and computed results. Here we have normalized cerebral arterial inflow here. And the comparison is indeed not perfect because it couldn't be perfect. It cannot be perfect, never. But it is close. And then we have here normalized cerebrospinal fluid here at the C2, C3 level, comparing the mathematical model result with magnetic resonance data. A very brief presentation on an application of the mathematical model to study the effect of bilateral transverse sinus stenosis on the hemodynamics and craniospinal dynamics. We are going to study then these two transverse sinus here, so with bilateral stenosis in them. And then we are going to compute the results. And what you see here are three sets of results in various compartments here. For example, superior sagittal sinus here, the left transverse sinus, and so on. And what we see is the healthy control in black, and these are computed pressures. Okay, so pressures are in black in all these compartments. And then when we put the stenosis in both transverse sinuses here, we have here the red bar here that signal an increase in pressure, which is very significantly in most of the compartments here. And this is the case in which you have a fully active collateral network. Okay, so the flow is obviously diverted and it flows elsewhere, and it still goes to the heart, obviously, but at the cost of increased pressure, as it should be. The extreme situation here, the worst case scenario, is when no collaterals actually function here. And then you have a huge increase in pressure in most compartments. And this value of 30 has been seen in some measurements around. Now, obviously, most cases, specific cases, will lie in between here. And the result will depend on how your collateral network will function. So here we see the effect here on various compartments of CSF, cerebrospinal fluid pressure, in the brain, in the lateral ventricles, the third ventricle, aqueductus sylvius, fourth ventricle, cerebral subarenal space, and spinal space here. At the bottom here, we see the distribution in time within the cardiac cycle of the healthy control, the stenotic case with collaterals functioning fully, and here the results in which collaterals are not functioning. Again, the specific case of interest will depend, obviously, critically on how your collateral network functions, and it will lie somewhere here in between. Summarizing the findings for this application here, we see that we can predict and we can compute that if you have intracranial cerebral venous outflow strictures, in this case intracranial, then there will be an increased cerebral venous pressure computed, disturbed whole intracranial dynamics, disturbed CSF reabsorption, obviously, increased cerebral spinal volume, and increased ICP, increased intracranial pressure, and disturbed cerebral venous return to heart. And each one of these points naturally has physiological consequences that one can discuss, but obviously there is no time for doing so. A general remark, as a form of conclusion, is that mathematical modeling offers a quantitative framework for adopting a holistic approach that includes the dynamic interaction of all major fluid compartments. But when I say all major fluid compartments, then there is here a huge challenge. At the moment, we have included the arterial, the venous, and the CSF and ISF compartments. But obviously, there is much work to be done, and much work remains to be done in the area of modeling. And there are huge challenges as well as opportunities ahead, of course. And I will mention just two potential areas of further research, being ambitious here. One is the microvasculature. The microvasculature connection between the arterial system and the venous system. What I mean is this one here, this picture on the left, depicts the situation I am trying to explain to you. Now, capillaries here, right at the bottom here of the scale, are tiny features, which are very difficult, perhaps even impossible. And Dr. Heike here perhaps certainly will have a lot to say on this. But the numbers are staggering, 10 billion capillaries in the human. Now, how can we represent the microvasculature that connects in a physiologically credible manner the arterial part here with the venous part going through the capillary bed here? Now, there is some very interesting work of Professor Lininger, who has given me this picture to show to you here today. And these works are reported in these two papers. We in Trento, who specialize in a sense on numerical algorithm for these fluid dynamic problems, are really looking forward to the possibility of deploying our numerical algorithm on realistic network of vessels like this one here. And the last one I want to mention is the lymphatic system. We all know from books what the configuration of the lymphatic system is, the functions, fluid balance, nutrition, and immunity, and the only asymmetrical way of discharging the fluid into the venous system is interesting. And here is a representation of the potential network for the lymphatic system given to us by one of our collaborators. But this is indeed very challenging because the lymphatic system here is characterized not just by the vessels, but also by the very large number of lymphatic nodes. The human body has about 500 to 700 nodes. Each lymph node is a very complicated three-dimensional structure in which you have the very strong interaction between the vasculature and the lymph, because in each node you have the presence of the arterial flow and the venous flow, and much of the lymph actually discharges locally into the venous system, here. And the remaining part is discharged obviously in the neck veins here. So this is indeed a very challenging topic just for the lymphatic system alone, let alone combining this with the remaining fluids. There is already some work in the mathematical modeling of this. I mentioned a few illustrious names here. Also in Trento, we made a start here a couple of years ago. But this is indeed a very, very challenging topic. Thank you for your attention.
Well, we're in a little delay. Thank you very much for Professor Toro for his very elegant presentation. And now the final discussion with Lucas Muller that may drive it. Thank you.
Thank you, Professor Zamboni. So just very briefly, the panelists now are Professor Zamboni himself, and then Professor Pasquale De Bonis, who is a full professor of neurosurgery and head of the neurosurgery residency program at the University of Ferrara in Italy, and myself. So there have been, again, a few questions that were answered by the speakers during the talks. But I know for a fact that Professor De Bonis has a question that he wants to make, so I will pass the word to him.
Yes, thank you, Andreas. Thank you for inviting me. I have two questions. The first is for Professor Naganawa. And on his presentation, he has shown that in a paper from authors from Korea, there's an increase of perivascular space close to the superior sagittal sinus. And during advanced age, I believe that this is true, and that this is due to the Monro-Kelly law, because during advanced age, there is atrophy of the brain, and therefore, since the space must always be filled by fluid, there is also a spontaneous increase of perivascular spaces as well as spaces around major vessels constituting the lymphatic system. I'd like to say if he agrees with my statement or he doesn't. And the second question is for Professor Toro. Really, congratulations for your beautiful presentation. I need to talk more in depth personally as soon as we can about some projects. for mathematical modeling of hydrocephalus and special forms of hydrocephalus and chiari malformation, will fall within my areas of expertise. I have only one question, and that is, you have shown that with increased venous pressure in the intracranial system, there is also a CSF increase. Well, always depending on molecular law, I have the same idea, and I believe that this increase is mainly in the perivascular space, and this is because we have in patients with idiopathic intracranial hypertension a sort of brain swelling with small ventricles, and that is there's a movement of fluids. And these fluids tend to be more within the intravascular spaces and within the brain parenchyma than in the ventricles. And so that is the reason why we have slit ventricles in these patients. So I perfectly agree with you. I'm very happy that mathematical modeling can show that my previous statements are true.
Mr. Chairman?
Oh, yes. No, I thought.
I guess that Professor Nawanawa could not answer because he, concerning the first question, because his presentation was a recorded presentation. So unfortunately, he's not present in the meeting. And my suggestion would be that you can write to him. If you don't have the email, you can write to me. I can send you his email. Concerning your second question, thank you for your comments. We observe this phenomenon that we have an increase in volume of CSF where you have increased venous pressure. And the mechanism, at least in our model, is indeed very clear. You have the drainage of CSF into the sinus, the superior sagittal sinus, depends on the pressure difference between these two, between the pressure in the CSF and the pressure in the superior sagittal sinus, which is part of the venous system. So if the pressure in the venous system increases, and it does increase if you have obstructions to the flow of the venous blood out of the cranium, therefore the pressure increases, and therefore the drainage of fluid decreases, and you have accumulation of cerebrospinal fluid, and therefore the increase in pressure.
Yes, the observations by Professor Toro, certainly what we observe in our model is, of course, conditioned by the modeling hypothesis, right, that we make, because this is the only thing that exists in a mathematical model where you put in equations you put in. So you can find a clear explanation of what's going on. But there is certainly room for improvement in the way we do things. And one thing that shows up is the importance, the relevance of collaterals. It depends on how collateral work in your network. So that will characterize the impact of a venous malformation, for instance, at the intracranial level. So there is, I think, a need for functional indicators of, the significance of certain venous malformations, for instance. That is something. Okay, so I think that Professor Benveniste had a question that I wanted to ask. So please go ahead.
Yeah, I'm sorry. I kept writing in the chat because we cannot post the questions, and I didn't mean to be rude. But I have a question for Dr. Lininger, and I was really intrigued because as an anesthesiologist, obviously, we have the intrathecal space is our access, and it's been a mystery, and pharmacokinetics dynamic models have not really been very strong. So I really appreciate your presentation. One question I had was, we had initial catheter techniques, microcatheter techniques that we used for indwelling spinal delivery of local anesthetics. And once, because they were so small, they happened to actually curl up often in the sacral part of the spinal interthecal areas. And it looked like in some early studies that there was actually turbulence there. So, you know, it wasn't like following the normal fluid flow dynamics. I mean, it seemed to be more complex in certain areas of the spine. Have you incorporated turbulence in any of your considerations for these models?
Well, very good question. The major teacher here has been the experiment. And what I showed is if you allow that the fluid bench model that I made has still conserved the essential features of the injection, what we see is that at the catheter tip, we see phenomena that are consistent with turbulence because of the high impulse at the catheter tip. And for instance, we have seen that if you take the same injection volume from a pump and change the needle diameter, you get different patterns of distribution. And there is no modeling assumption here because it's just a physical experiment, if you want. And the injection impulse is significant for the initial spread of the drug. And so, for instance, a very thin catheter allows you or forces you to give more impulse to the injection, but that additional impulse gives you a wider distribution. So there's a real correlation between the force that you apply and how much dispersion you get. And the reason I use these in bench models is to first get a feeling about the physics of the phenomenon before we start modeling. And the turbulence at the catheter tip is definitely something we see and is something that a reasonable mathematical model needs to include. But the phenomenon that I want to point out is that even in the absence of what we call normally high Reynolds turbulent flow, we have by natural pulsation mixing that is causing eddies and other complex fluid phenomena that you never see in low Reynolds number flow. But you see it because the fluid is forced around these microanatomical features. And therefore, this is a complex flow not caused by a large momentum, but it is a complex flow caused by the fact that the fluid has to force itself around these microanatomical features. And I think it's reasonable to suppose that the enhanced mixing that we see is not coincidence, but that the microanatomical features of the spinal cord help the mixing of drugs or mixing of solutes or the displacement of wastes, even with low energy. So you don't have a turbulent machine that squishes this around, but at a very modest pulsation, you get much enhanced mixing because the intricate nature of the microanatomical subarachnoidal space, which seems to make sense. So,
thank you. That's wonderful. I did have another question. Can I ask that now, Lucas?
Yes, please go ahead.
So this is for everybody, maybe, and especially maybe Dr. Toro. I mean, we are all interested in the venous outflow around the perisagittal sinus area and the discussion on the arachnoid villi being one way versus parasagittal hyperintensities that Eide and Ringstedt have reported. But we still don't know the anatomical construct that are really responsible for these outlets. Do you have any, or is that, you know, anybody really can answer? But I think this is a bit of a mystery, even in the clinical literature.
I would pass the microphone to Professor Zamboni. If Paolo is still with us.
Specifically on the model that was shown before, I can answer that we are in the model, we are just using the let's say equations that reproduce what is observed or what is reported in the medical literature, or what is understood until now about physiology. So, for instance, in that model, CSF is drained only by arachnoid villi, and they behave in a certain manner. So this is why I said before that there is much improvement to be done. But the nice thing about mathematical models is that if you have an hypothesis that you want to test, then it is, yeah, I would not say straightforward, but it's something that can be done, yeah, in a controlled manner. So that is the utility.
If I can add something to the question, there have been some beautiful works by the group of Oreskovic and Marian Clarissa, showing that arachnoid villi probably are not the site of CSF absorption, as we all believe, because the first and only experiments showing that arachnoid villi represent the site of CSF absorption use trachers injected too dramatically and not in a physiological way. And so these tracers destroyed the arachnoid villi. Marian Clarissa and Oreskovic instead used the tritiated water. And so that was simply water, or CSF. It has not, it is not heavy and moves freely through the intracranial space, both within the parenchyma and in the CSF. And they showed that there was a constant equilibrium of water among several spaces, an equilibrium of water, meaning that there is not an absorption and a production in fixed places of the brain, but the CSF is absorbed and is produced in the brain, in ependyma, and in the subarachnoid space as well. And there's a constant movement of fluids among these compartments. So I agree with Dr. Burnside that arachnoid villi still constitute a sort of enigma. Nobody knows what they are for. And I by myself, during surgery, during neurosurgical procedures, because I'm a neurosurgeon, I often encounter arachnoid villi, but sincerely, both in patients where I encountered them or in patients when they are destroyed or invaded by cells, there's no difference in the presence of hydrocephalus or other pathologies linked to CSF disturbances. So I agree with the group of Marian Clarissa that arachnoid villi, in my opinion, are not the place where CSF is absorbed.
That's very important. And certainly in the rat, they're not there. So, we agree with you from that point of view. But I still think that, the contrast enhanced MR platform that we use kind of give us much more information on the ventral part of the brain in terms of reabsorption. We don't see much activity along the parasagittal sinus area, and that's probably a technical issue. But anyway, we have a lot to do. Thank you.
Thank you very much. Yeah, thank you very much to all to everyone. I think we have to wrap it up because we are significant.
Indeed.
We have a
Yes,
significant delay.
right.
Yeah, please.
I would like to thank all the speakers and panelists, and also the International Society for Neurovascular Diseases. It has been a great meeting, and thank you to the audience as well that has reached very high numbers. And perhaps we shall organize a similar meeting in the future. I mean, it seems as if there is a lot of interest in this, and this multidisciplinary character, I think, has been also an interesting part of this meeting, which we'll probably try to keep in future meetings. Well, I was going to say have a safe trip back home, but of course, this is not the case. Stay safe, take care, and I'll see you perhaps in the near future. Bye-bye.
Thank you, everybody.
Thank you. Thank you. Bye-bye.
Thank you.
Bye.
Bye-bye.